Good morning. This is Chad Versio, the chair for pediatrics here at RUHS, and we're going to be joined by Dr. Mike Masiska from our emergency department, who's been very involved in disaster planning overall for the county and specifically with this COVID situation. We'll also be joined by Dr. Jeff Leung, who is our chief medical officer for the RUHS Community Health Centers, and has been very involved with the statistics for this. Very excited to have their involvement today in this webinar, and I think they're going to share quite a few stats and things like that as they have done in the past. They are not as of yet on the call, so I'm going to start covering some of the statistics for Riverside County as of today. If you look at the county website, you can see that we've tested almost 32,000 patients so far. There are almost 3,000 that are confirmed positive cases, currently hospitalized 240, which includes 72 in the ICU, and then there are 93 deaths total for Riverside County. For San Bernardino County, they have tested about almost 14,000 patients. They have around 1,400 patients that have been positive, and they have around 67 deaths. So that's their statistics. And I think it's quite challenging. I don't know if any of the rest of you have been following kind of the projections for this. Dr. Leung has obviously been doing that for our county. And so, it's been interesting to follow different organizations that are, performing these projections. One of the ones that I've been following recently is the Lown Institute. That's LOWN. And they're an institute that's primarily focused on high value care in healthcare and making sure that the providers and others in medicine recognize both high value and low value care. But obviously with this situation, they've devoted some focus to COVID. And they have been updating their projections daily pretty much. And you can follow along on their website. They have quite a few countries that they cover. Not all of the countries that they're mapping, but the United States in particular, it's been interesting to follow. So I've checked this every few days, and even just probably 4 to 5 days ago, they were projecting around 53,000 total deaths for the United States, and currently they are projecting about 92,000. So it's a significant increase. Which obviously is not entirely in line with the other projections coming out of the federal government, at least previously, which had kind of lowered that to potentially 60,000 deaths. And then for California specifically, they have 2,500 deaths, which was up from the last time that I checked a few days ago, it was 1,300. And so they are, seeing that we are well, we haven't seen a huge surge. We are seeing more of an uptick in deaths than we were projecting, even a week ago, probably. So we'll see how that all pans out. But that's, some of the projections that they're doing. So let me give a pause to see if Dr. Masiska and Dr. Leung have been able to make it onto the call or the webinar.
Hi, Chad. We're here.
Oh, hey, Dr. Leung and Dr. Masiska. Thank you. Good to see both of you guys. It's been too long since we've been able to see each other in person, but hopefully we'll be able to do that soon. So I just covered, I don't know at what point you came on, I just covered a little bit about the local statistics, today, and then also mentioned, some of the projections that we're seeing that I've been looking at following different organizations as they kind of try to make sense of this situation. So I'll turn it over to you guys, and then I'll have some questions.
Thank you, Dr. Versio. So if it's okay, I can share just a few slides, and can you see?
Yes.
Okay. So I think you already went over today's statistics.
Mm-hmm.
And just really briefly, I think a question that you had asked, Chad, was in terms of modeling and thinking about kind of reopening. What are some of the considerations? So this is like a really short crash course on that. Some may be familiar with the federal guidelines that have been published. They generally look for a 14-day trend, downward trend in whether it's symptoms, new cases, positivity rates, or kind of there's sort of and or situations, and then finally they want to make sure that your hospitals are not in crisis situation, and that you do have an ability to sort of test healthcare workers. So they're asking that you meet all of these things in order to be able to start to reopen. And they've got sort of 3 different phases for reopening. But at each phase, you're supposed to make sure that you qualify for these gating criteria. So you'll probably hear more and more reference to that, and we'll come back to that in a moment. This is just kind of revisiting some of our data. So if you look at our numbers, in terms of tested and confirmed, we know that there's some pending tests there, but in general, our positive rate is about kind of, even from here, you could say it's about 1 in 10 or 1 in 11. And if you look at sort of a couple of the graphs that are published, in terms of our cumulative confirmed cases, it does seem like it's slowing from the past few days. And it's, the scale of the graph always affects the shape of the curve. And then the deaths by date, because that is a much smaller scale, it looks like it's continuing to increase without much of a slowing. This is a graph that probably most people haven't seen. It's something that the epidemiology team has been developing, and I think they want to be able to publish it soon. But in blue, you can see the number of new tests done per day, and in yellow, the number of new cases identified per day. And really, the data is probably pretty good through 3 or 4 days ago. And the reason why you don't want to look at the most recent couple days is because of the turnaround time for the test results. So for instance, on here, I just posted on April 18th, you could see the positive rate was 11.84% for those labs being sent out and coming back. And but the total number of results at that moment in time was only 248, which is much less than kind of what we typically get in a day. So on the 18th and 19th, we were starting to get results back, but really you can see on the 16th and the 17th, that was probably more typical for the total number of labs we do. And so from this, if you look at the yellow, you can see if our new cases are either trending, downwards, if they're leveling off. And again, you really have to ignore the past few days because of the test result delay. If you're just looking up through the 17th or 18th, it doesn't look like we've had a drop off in the positivity rate, which you might expect if you're sort of through the peak of an outbreak. And then in the bottom lower left-hand corner, I stole this from Dr. Kumar's chart, our Chief Health Information Officer. He's got an internal dashboard, and you just see a really plain linear trend line showing number of new positives by date, and you can see that linear line is trending upwards.
Why is that one trending upwards, but then the yellow, shouldn't that match the yellows on your chart?
It should. There's slightly different data sources. And we do think that if you kind of take the days into account, they eventually do match up. But you can see, just even by the way you graph things and how far you look back in time, it can look remarkably different on a chart. This is also stolen from Dr. Kumar's chart. It's another way of looking at positivity, and it purely is just graphing sort of the percent positive tests per day. And you can see, in red is the positives for Riverside County. That's the first box. And then the blue is our county positivity rate. And then for California, you can see how we compare. So there's really not a drop off for that blue positivity rate, which you would like to see before you start reopening.
And Dr. Leon, I just want to ask a question about that. There's multiple. I think this speaks to the complexity of this modeling, which is something I kind of wanted to ask you towards the end.
Yeah.
But there's multiple things that can affect that positivity rate. Like you're saying, one of the things could be that we're seeing a decline in the number of cases, and so people are getting tested. The other thing is new testing capacity.
Right.
So as many people know, the testing capacity has been not quite adequate for our situation up until now. And so once new tests become available, then you can test many more people, and that may result in differences in the positivity rate as well, right?
Absolutely. And that's just a reminder to all of us that we have to be very careful about comparing absolute numbers of positives, either county to county or state to state. Because when you look at the total positive numbers, it's really meaningless unless you know what the testing denominator is. And so, for instance, taking Georgia as an example. So not to pick on them, but they're kind of in the process of reopening as early as the end of this week. They probably have about 7 days of a downward trend, so they haven't hit 14 days yet. And overall, it looks pretty reassuring. So if you just look at the graph, you're thinking we're probably starting to trend downwards. If you look though at the total test done, which is in the kind of the right upper hand corner, and you do a quick calculation on the commercial labs or their public health lab, you see that their positivity rate is somewhere between 20 to 25%.
Wow.
Which means that 1 out of 4 or 1 out of 5 of their tests are positive. And if you talk to anybody, any epidemiologist, they will tell you this rate is far too high to make an accurate assessment. Our own public health lab is about a 1 in 5 positivity rate. And that's because they only take the sickest of our patients. So generally hospitalized ICU patients who are symptomatic. And that's why we know that 20% is acceptable for a public health lab. But in our community testing and in our clinic setting, our positive rates can range from 1 in 10 to 1 in 20. And really the experts across the world say that you need to get your positivity rate below 10% before you can even start to say that your testing is getting close to capacity. And if you can imagine a scenario where your testing capacity is stagnant, it doesn't change. You can only do, let's say, 1,000 tests per day. But you've got, if you have more kind of spread in your population, you may actually not pick that up. You may plateau simply because of your reaching a maximum of your testing capacity. And in Riverside County, we've been actually trying to continue to expand our capacity. We're probably at twice the capacity today than we were 2 weeks ago. So sometimes it looks like our numbers look bad because we're identifying a lot of cases. But actually, if you look at how we rank in terms of our testing, we probably are testing out of all the counties in California, we're probably number 2 out of 58 in the number of tests we perform per capita or per 100,000 people.
We got to get to number 1. I don't like being number 2, Jeff. You know that about me.
Yeah.
All right.
We'll get there.
Maybe
I'm only slightly competitive.
So when you look at Georgia, graphically it looks encouraging. But when you look at the denominator for testing and the fact that their positivity rate is 20 to 25%,
kind of like us in San Bernardino.
It's a little bit scary. And then, this is just a framework for what Governor Newsom has set up, 6 indicators to be met, before stay-at-home orders can be eased. In case anybody hasn't sort of followed the press conferences and you haven't done the reading, this is kind of a cheat sheet on it. But really, it looks at your testing and your contact tracing capacity, what your plans are for your high-risk populations, whether you can handle surges in your hospital settings or not, whether you have people kind of partnering to work on treatments. Do you have plans to safely reopen for your businesses and your schools and your childcare facilities? And then what are your triggers for quickly reinstituting restrictions in case you get outbreaks? Very different framework than the federal guidelines. And there's other frameworks popping up as well. So I think one of our challenges going forward will be, to figure out, do we kind of straddle all these different frameworks? Do we kind of make up our own? We just opened up golf courses in Riverside County. I'll pause right there and see if there are any questions. And Mike, I know you've got updates as well.
I don't see any questions in the chat. Yeah, I have some questions for you, Jeff, but I'll let Mike go first because I'll probably have some questions for him, and I want to just make sure we have enough time for what he's going to cover as well.
Yeah, I don't have a ton. I'm having a little bit of technical difficulties, but on the camera here, I'm going to see if I can show you. Is that going to? Oh, that does work. All right. So you can kind of see that we continue to trend upwards in our hospitalizations, and I'll share those numbers with you, but it's a slow trend upwards. We peaked initially about 10 days ago. We were up to 247 hospitalizations. We dropped all the way down to 207, and now we've just sort of been inching along to 240 patients countywide in our hospitals. And what's interesting about that is that the total number of PUIs tends to be dropping at times, and it has to do with the fact that our hospitals have quicker turnaround in testing than we used to. And so at any given time, we were sort of seeing this downward trend. So that also offsets the total number of hospitalizations, because before you would have a lot of positive COVID patients and you'd have a lot of PUIs. But your hospitalization numbers of positives are inching along upwards, but you're also seeing a downward trend in PUI. So that number is just shifting up. Right. However, just yesterday, we had a pretty significant bump in PUIs, and the majority of those will convert to positives. And so, I think we follow this trend very closely. Granted, the doubling rate for hospitalizations, it's pretty flat if you take into consideration the PUIs that are shifting up. So we just haven't seen this ratcheting up, and that's probably as good an indicator, right? If we're talking about opening up and the impact on the healthcare system, then we really want to be looking not just at what's going on in the community, but ultimately what's happening in our hospitals. So the hospital capacity, has been slowly increasing. In the ICU, we've seen a pretty steady, almost a flattening over the past 10 days. And similarly, the number of PUIs is dropping, so it's been pretty level. I do get the sense in looking at hospital capacity that there has been a slight increase in total admissions over the past week. And I suspect what will happen is, as people, because they've largely stayed away from our hospitals, we're really recognizing nationally that the messaging got out to people: don't go to the ER unless you're really sick. And locally, we've seen anywhere from a 30 to as much as a 60% reduction in ED volume. That's including chest pain, strokes. And so there is some concern that the messaging has been so clear that people are actually so scared to come to the hospital that they're not coming for conditions that they really need to be there for. And so there may be mild MIs and strokes, and even that aren't getting detected early, that we could end up seeing a big impact on the healthcare system down the line, whether that's weeks or months or over the course of years, that the public health impact of this could be pretty significant. So we're looking at ways to be able to message to the community that our hospitals and our ERs are safe, but we're also trying to put mechanisms in place right now that really do make it safe. So if somebody comes in and they have chest pain that's not COVID related, that they're not going to get exposed. And we want to be able to make sure that all of our hospitals, and then Jeff and I are looking too at not just our ERs, but all of our clinic access points. In order for hospitals to get back into the business, we need to be able to convey to people that this is a safe place. And I know Dr. Johnson spoke the other day to this group. Our pregnant patients need to understand that it's a safe place to come. We need to have mechanisms in place to protect them, and down through the line. So pediatrics, right, Chad? People want to bring their child in to get their other vaccines, but we have to give them the confidence that this is a safe place to come. And there's a lot of things that need to go into doing that. So I think What we haven't seen is a full flattening of the impact on the hospitals, which matches what you're seeing out in the community. As we open things up, I think we're going to see a bigger impact. Some of the concern that we have on the acute care end is that from a disaster management standpoint, and I'm just speaking bluntly and openly to everybody here, is that it's easier to deal with a crisis when it's in front of everybody. And the big surge, right? Everybody stops doing everything else that they were working on. There's resources getting pulled in. There's money. The state's supporting you. It's a lot more difficult, and I can attest to this as an ER director, when it's a gradual progression into this. And so we do need to keep our mind and our eyes on that, that the total area under the curve, so to speak, is probably not going to be flattened. There's concerns about a second surge, and not to be the alarmist here, because I was the guy driving the initial surge, but we have to have all the PPE, the protective measures in place for our hospitals, like purchasing that, acquiring that, looking at novel respirators, looking at PAPRs for whether it's the fall, whether it's because people make decisions to reopen things too quickly. But our healthcare system needs to be strong enough. Dr. Flowers is sitting across from me. We're still working on staffing options if we were to get pinched with staffing, because even right now, what I'm hearing is that some of our hospitals with nursing and physicians, that we have people that are out sick, we have beds that we can't staff, and we're not even at the point to where we're busting at the seams yet. So I'll tell you a tale of two stories. So 2 years ago, when we had the major flu outbreak, we got a lot of attention. It was all over the news. The ambulance traffic was up. So there were a lot of additional resources that came in to support that effort. And it actually made it easier to manage because it was on everybody's radar. A year later, we had just as much volume coming in, but we didn't have all the attention, the resources, as many nursing travelers, and it was much more chaotic. And so I think I just share that is that it's something that we need to be mindful of, that we things are looking good. There's a lot of reassurance, but we still need to be working with our hospital leaders and our team to build an infrastructure that can support something, because we just don't know fully what's going to happen. The discussions on the acute care disaster management end, right? How long is immunity conveyed? We don't know. We see people that are shedding virus, and what does that mean? So there's a lot that still remains unknown with respect to planning for a full-scale surge.
Yeah, definitely. Thank you, Dr. Masiska. I do want to highlight that, people have been avoiding care. Unfortunately, there was a couple of cases of pediatric deaths in Orange County where parents had delayed because they were afraid of coming to the ER, and they delayed to the point where, their kid unfortunately had passed away because of waiting to seek medical care. So it really, I do think it's very important that we figure out how to get that messaging out there, so that people don't delay on seeking medical care. So one of the questions that I had, wanted to ask kind of both of you, and you talked about how difficult this is when it's not when it's not as severe as people probably thought it might be. And that's, with the original peak kind of that was being projected, if social distancing or physical distancing wasn't put in place, was very, very high and potentially to overwhelm healthcare services. That also would have made much more rapid the time period where we would be experiencing that peak. However, with flattening the peak, which fortunately we've been able to do here in Riverside County, that also extends the time period for which we may be seeing that peak. Is that partially correct, at least?
Yeah, that's absolutely true. I mean, if we just sort of allowed for things to happen naturally and we weren't proactive, then we would have spiked quickly, but we would have spiked early. And everything that we do to slow it down not only pushes the peak down, but it pushes it out and forward, just like you mentioned.
Right.
And then I just would add, a reminder that with the recent antibody studies from Santa Clara and Los Angeles County, we now have a pretty good idea that our actual number of cases is probably 30 to 80 times more than our reported cases, which means that probably between 3 to 5% of our population was infected at least 3 to 4 weeks ago. And if you factor in, a little bit of doubling time in between, we probably have at least 1 in 20, if not more people who have had the infection in our area.
Okay.
Yep.
And so, have you seen anybody, based on any other countries, or possibly on New York, how long is that flattened curve lasting? Is there kind of any sense of what we can expect for how long, that time period of where we'll be at a plateau before we start to see a decline might be?
I don't think we know yet. I think, we've got a couple examples in which people were able to either clamp things down very quickly, or, in China, where you have probably the most severe reaction and response with 76 days of lockdown in Wuhan, and they're sort of returning to life right now. But short of that type of restrictive policy, anything else is going to be multiples longer in terms of time to kind of get back to normal. So,
Right.
Yeah, it's funny. It's interesting. If you really just base the policies around the 5 probably things that we absolutely know to be true, then a lot of the other things become very easy. It's all the speculation about what we don't know. So,
Right.
if you mask, you reduce transmission. Social distancing works. And then, we also know that if you reopen things too quickly, you'll end up in a second wave. And then after that, everything's off the table. Is the 100-degree weather that we're going to have this next week going to decimate this thing? Nobody knows, right?
Right.
It could have zero impact. It could have a profound impact. So there's just so many variables. What does immunity mean? Is it permanent? Is it partial? What percentage of people develop immunity? That's all off the table. And so it's going to take time, which is Americans, we lack patience. And
we definitely lack patience. So Jeff, I did want to ask you a little bit more about the complexity of the modeling for this, projecting forward and that kind of thing. There's, as you mentioned, really in this scenario, we don't have, or it's very challenging to be able to look to any other countries or even any other states on how this may progress, because the situations are so different, and there's so much we don't know. So as your team is kind of working on this modeling and the projections and things like that, how are you guys kind of thinking about that? What kind of things are you taking into account? I know that I've seen people on social media that are less, they'll just flat out say the projections were all wrong, blah blah blah, and in my mind, it's just, this is incredibly complex, and they don't realize that complexity and how difficult is that stuff is. So I just kind of wanted to hear your perspective on, from your team, how are you kind of managing that ambiguity, that uncertainty, and yet, creating some certainty about the things we do know, like you were saying, Mike.
Yeah, so great question, Chad. I think, first of all, we've got some other countries to look to, to see how, if you do certain things well, how that impacts your curve. We know how it goes if you don't do anything well. I think what we don't know is, what if you do some things partially and you sort of
Right.
keep changing and pivoting? And I think the hardest piece to account for is sort of our own behavior as a community each day. So, when we had the governor's orders and our public health orders to stay at home, even the modeling for University of Washington and the UPenn model, they were all kind of premised on everybody staying at home and social distancing for a certain amount of time. But
Right.
what nobody predicted was, well, if people get restless before then, and you start getting a partial reopening and people are sort of semi-compliant, but they're starting to gather, we're starting to reopen some states. Now you're in this hybrid state. And I think, we're going to end up sort of in between clean models. In other words, we've got clean models for worst case scenario, clean models for best case scenario, clean models if you do everything 100%. I think we're going to end up with what's actually going to be probably one of the hardest situations, which is sort of this in limbo state for months, if not years. And I think that's going to be the hardest part. So how do you return to normal life where there's still some concern for infection and spreading, and people are wanting to do all the normal things that they do. I think we're going to be stuck in this state for actually quite a long time.
Yeah. Kind of how I see it, in fairness to our EPI team, is that the models initially always had several projections, but all that people wanted to focus on, and largely what we wanted them to focus on, was the worst case scenario, and the intent to use the model as a tool to avoid that scenario. And
right.
So, and I've heard, you know, the EPI team always likes to say what all models are wrong and some are useful. So it was useful to the extent that it changed behavior, and it was true to the extent that if behavior didn't change, it would have been accurate. So, but on those models, there were other curves, but that wasn't the emphasis, both from the media, really from our point, and from our preparation, because if you banked on that model not happening, the potential downside to that could have been catastrophic, right? It would have been unacceptable to not have hospital beds, to not have ventilators. So the same people that are criticizing us now for the model being wrong were the same ones that were asking how many hospital beds, how many ventilators, and trying to get the gotcha of you're not going to have enough. So it's just the reality of this being a very public process, and people need to emphasize, you know, it's not very interesting to talk about the times that we were right. And so I've even tried to coach our team that getting away from using models as predictions, and we interchange the word projection from prediction. If you predict something, then it can be wrong. If you project something and you model it out, then it's just a possible scenario. And the linguistics that we use and the language that we use to describe it shapes people's mind and culture around things.
Right. Yeah, definitely. All right. So any last kind of things that you want people to think about, consider, you know, over the next week between now and next Wednesday?
You know, I think we know that it's tough to be in this state of ambiguity right now. I think, you know, a potential good topic for the future is thinking about the reopening and kind of the role of testing. And I know there have been some discussions about that. But, you know, really thinking about how potential testing either changes our decision making or doesn't change our decision making. And in terms of planning, how many sort of variables do we want to account for as we try to reopen? So, you know, maybe a potential future topic to think about.
Yeah, definitely.
I think what I would say, the 30 people that are on this call or more, you're all an expert in your own area. And there's a tremendous amount of hope here, right? The fact that the virus was probably in our community sooner means that the mortality rate is probably even lower than we initially projected. So, you know, life will be different when we move forward. But I think each one of us, like for me, I'm working with correctional health in the ER to figure out how quickly can we get our department back up to functioning well, functioning normal, to be able to support everything else, which is getting the economy back. Like, I want to see businesses opening. I want to be leaning into that. So how do we go about you know, working constructively? And so for your department, it's, do you have enough PPE? Do you have, like, what are the needs that you have? What are the things that are within your control that help us meet those 6 things that you showed at the beginning? And not focusing on, because thinking a lot about some of these other things, it's just going to take time, right? The antibody process, the vaccines, and we can spin our tires in the mud trying to address questions and issues that are far removed from the ones that we can actually influence. And so I think if we each take ownership over the areas, while it's fun and interesting to debate a lot of the things that are outside of our control, it's emotionally exhausting, and you can waste a lot of time and resources trying to get there.
Right. Well, thank you both so much for what you're doing. You know, I know that you both put an immense amount of time into this, and I'm sure emotional and psychological energy. So thank you for what you're doing for the county as a whole, and spending a little bit of time with us this morning. If you have any handouts, if you can please, you know, that would be helpful to those on the call. If you can let Christine Ramsey or Yolanda know, so that we can distribute those. And then obviously people can tune into the Riverside County website, which has all of the latest statistics on it as well. So thank you so much for joining this morning.
Thank you.
Thanks.